ครับก็ขอเชิญอาจารย์เลยครับ
Okay, thank you, Dr. Kitisak. I would like to present the pediatric neurovascular disease this morning. I have no disclosure. So, a 10-year-old boy presented with a acute right hemiparesis. In the brain CT, you can see the hematoma in the left parietal lobe. After the hematoma removal in the MRI, you can see the clearly see you can see the AVM nearby the hematoma. The angiogram, you can see the AVM nidus here and feeding from the MCA and drain to the cortical vein. In the AVM, we show the embolization to decrease the AVM size. And sometimes if there is a aneurysm inside, you need to seal it because it seems to be the breathing point. So after treatment, through embolization, you can see the AVM this. So after that, the patient underwent the surgery. A 2-year-old girl presented with the left-sided weakness. In the non-contrast CT scan, you can see the hyperdensity in the right basal ganglia. And when the contrast injection, you can see the venous pouch. So this seems to be the thrombus of venous drainage, and see the multiple dilated vessels in the bilateral thalami. In the MRI, if compared to the CT brain, you can see the progressive of the venous pouch in this image. And there is a periregional edema here that's caused the symptom in this patient. And you can see the nidus here. In the angiogram, it's a beautiful angiogram. You can see the AVM nidus here in the bilateral thalami and drain to the deep venous system and reflect to the superior septal sinus. And see the association of the occlusion of the right dural venous sinus. A 5-month-old girl presented with a seizure. This is an AV shunt. You can see here, AV shunt here in the trochlear hyalophylla and left transverse sigmoid sinus, and fed by the bilateral mid-meningeal arteries. And see in the brain drainage, you see the congestion of the brain. This disease is the infantile dural AVF. Sometimes this disease is associated with the congenital anomaly, such as this, posterior fossa cystic lesions with the cerebellar hypoplasia. This is the Dandy-Walker syndrome, so associated with the ventriculomegaly. And often we can see it, this lesion in the scalp. This is the venous malformation. It can be associated with the dural AV shunt in the children. After the follow-up, 6 years later, you see the new lesion of the venous malformation also. It occurs in the orbit in the left side and can cause the proptosis of the left eye, and sometimes it compresses the optic nerve. The next case is a 1-year-old girl presented with a delayed development and macrocephaly. You see the enlargement of the dural venous sinus and see the calcification in the wall. In this image, you can see the calcification in the subcortical white matters. It represents chronic venous hypertension. In the contrast imaging, you see the partially thrombosed of this venous sinus and see the multiple dilatation of the vessels. This image is a hallmark for the dural sinus malformation. In the angiogram, you can see the AV shunt around the dural venous sinus. You see the shunt here and here. And after the treatment, we embolization with NBCA, and the dural sinus can thrombose, and the AV shunt has gone. And so again, you can see the venous malformation in the scalp, in this AV shunt also. This case for the 13-year-old boy presented with the seizure. You can see the enlarged venous pouch and drain into the vein and feed by the enlarged middle cerebral artery. So this disease is pure AVF. For the disease is very difficult to treat it. In the angiogram, you can see the vision here. This middle cerebral artery, this is a venous pouch, this is a draining vein. In the disease, you need to angiogram the right ICA and the vertebral artery also to see the multiplicity. So for this case, it's no another vision. For the treatment, in our institute, we use the NBCA for treat it, but it's difficult to treat because sometimes NBCA can fly into the vein. So we have some technique to stabilize the NBCA by using very strong NBCA for all the pure NBCA plus the tantalum powder. And keeping low blood pressure during NBCA injection. Some interventionists put the coils inside this venous pouch to prevent the glue fly out to the vein. For this case, we use the we use the Bautechi 1.2 French and inject the NBCA 2 cc mixed with the lipiodol to 0.2 cc with the tantalum powder here. This is a glue plug in the artery, in the shunt and the proximal vein. After the follow-up, the venous pouch completely thrombosed and shows the fistula has gone. For the VCAM, it's the AV shunt of the median prosencephalic vein. That means it's the precursor of the vein of Galen, and sometimes you can see the remnant of the Fauci sinus also. For the classification, Lachun is divided into the two types of this disease. The first one is the mural, the second one is the choroidal type. The common arterial fissure are the choroidal artery, either the anterior and posterior choroidal artery. The symptom of this disease, it depends on flow. So in the neonate, if the aviation is high flow, the neonate presented with the cardiac failure because the high flow return to the heart and then it causes the failure of the pumping. In the infant and children, the flow is less than the neonate. The patient can have the neurological symptoms such as seizure, hydrocephalus, the macrocranial, sometimes the delayed development. So this diagram is from surgical neuroangiography books. It's the same as the previous slide. It can occur in any age of patient. A 5-day-old girl presented with a congestive heart failure. You can see the CT scan. You see the multiple dilatation of the vessels, and you see the dilated median prosencephalic vein. And MRI, you clearly see this. And see this disease is a PCAM. It's supplied from the anterior and posterior choroidal arteries and drained to the Fauci sinus. Because of the patient is newborn and the low body weight 3 kilograms, for this patient, you have the limitation for using of the contrast media because you use just the 15 cc for this angiogram, but you need to embolization as much as possible to decrease the symptom of patient in the cardiac failure. So in my practice, when I review the MRA, you see the anterior and posterior choroidal artery feeders, and you need to choose. You need embolization which vessel first. So after that, you go through the dead vessels to put the guiding catheter and inject this angiogram, and you can see the posterior choroidal feeders. After that, you make the 2D roadmap from these angio images because you need to save the contrast, right? And you need to run contrast again. So after that, you put the microcatheter and embolization. So this is the first glue injection. And then after that, if you need to embolization further, in my practice, I think you do not need to run angiogram again. You can use the same roadmap, the previous roadmap, and then put the next microcatheter for the second catheter, third catheter, and then into the sixth catheter. And you can embolization for the sixth glue injection in the this station. And then you have the contrast to run angiogram. You can run the vertebral artery post treatment. And you have the contrast to run the right ICA also. You see the feeder, you see the brain drainage, and then you can run the left ICA also. In my practice, I think this technique, we have the more contrast to do anything. So after the treatment, the patient improved. No dyspnea, but still a little bit fatigue. After the follow-up, you can see the decreased size of the median postencephalic vein. For the second angiogram, you see the decreased flow of the VCAM, and I inject the glue in this posterior choroidal artery, and then move to the right ICA and inject glue the right ICA also. After this second embolization, patient is very good, alert, and more oral feeding, but still have the mild development in the motor aspect. We have planned to next angiogram in next month. The next case, a 13-month-old girl presented with minor head injury. So patient had the CT scan in the private hospital. You don't see intracranial hematoma, right? And anything else in this CT scan? You see this one, the abnormal dilatation of the vessels. The MRI, you can see enlarge the median postencephalic vein and see the dilatation of the arteries, and you see the VCAM here and the refractive sinus. For this case, no symptoms, we consider as the incidental VCAM. So the angiogram like this. So it's I think it's the incidental finding. You need to treat it or not. But we decision to treatment this patient because the disease is potential for the develop the neurological deficit. So we embolization here for the 2 sessions. And embolization, the direct fistula here and multiple feeders. After this 2 sessions of the embolization, you can see the much decreased flow of the VCAM and the residue a little bit. For some disease, the patient present with the mass in the face. Sometimes it's enlargement, sometimes a trinket, and you can see the bluish lesions in the face. And you see the hypersignal T2 in this area, and see the calcification inside, we call the fibrosis. And after the enhancement contrast, you can see the enhancement in the lesions. So this lesion is a venous malformation. Sometimes the venous malformation occurs in the orbit. So you can see this lesion and the cause proptosis of the left eye, and sometimes they compress the optic nerve also. For this lesion, the ophthalmologist is difficult surgery and how to treat it. In our institute, we treat this lesion by the percutaneous puncture where the orbit. So by the ophthalmologist, the puncture, and then after the puncture, we inject the contrast to test the tip of the catheter inside the lesions. After that, we inject the bleomycin. The bleomycin is a sclerosing agent to treat these lesions. But this technique, you need to avoid the high volume of the bleomycin because it causes mass effect and may cause the optic nerve compression. After the follow-up, you see the much shrinkage of the venous malformation. You can residue this, and the proptosis has gone, and patient very happy. A 7-year-old boy presented with bleeding per cam and hypovolemic shock. In the MRI, you see the abnormal vessels here in the mandible, and see the multiple dilatation of the artery. In the angiogram, you can see the AVM in the side the mandible and supply from the facial arteries. And you see the venous pulse here in the mandible, and see the another arterial feeders. The aim for this disease, we need to closure the venous pouch, because if we leave it, the patient will bleeding again. So we try to transarterial embolization for these feeders. For the right facial artery, we put the another glue. So you can see the glue here in the facial artery, in the venous pouch, in the mandible. It look good? Look good, right? But after we inject the glue and the control angiogram, patient have the bleeding per mouth, active bleeding. So we review this angiogram. You can see this glue is moved outside the venous pouch into the oral cavity. And you can see the contrast, a little bit contrast, leakage into the oral cavity. You compare this glue during embolization and post-embolization. It's moved out. So, how to stop bleeding? So, we compress the gum, the bleeding side, and in the meantime, we embolize the arterial feeders by the glue and by the particle to embolize the feeders. After that, the AVM has gone and bleeding has stopped. So I think it's just 10 minutes or 15 minutes. The patient has blood loss 700 cc. So the patient had lost follow-up and come back again in 3 years later, presented with progressive right facial swelling. So you can see the CT scan. You can see the CT scan, the AVM is a more enlargement, and see that this venous pouch in the mandible is very large. So in the sagittal view you see here. So in this disease, we need to treat it because to prevent the future bleeding per cam. So we need to occlude the vein inside the mandible. In the angiogram, you can see the multiple arterial feeder here, and see that this venous pouch in the mandible, and see the feeder from the contralateral side. So, but it's difficult to treat it because this route we can treat it for cure. So, in the first time, we try embolization for the transartery, inject the glue, but it's not success. The venous pouch is still there, and then we have the thinking about another route. Just the transvenous route is possible or not. We can go here, and go inside here. But if for this patient, the venous route is the tortuosity. I think it's very difficult to treat that. So another route is the direct puncture into the mandible. But you need to penetrate the cortex. So, fortunately, when I review the CT scan, you can see the one part of the mandible, the cortex has lost, or the very thin. I think at this side, we can puncture of the needle inside the vein. So we mark the location of the puncture site by the use the floating tooth for the landmark. So this area is for the puncture site. So at the puncture here, inside to the vein in the mandible. And you can use the CT scan for the guidance of the direction of the needle tips. And sometimes you can see the location of the tip also. After that, you inject the contrast media to see how the venous pulse is, and then to see the tip of the needles. And then you can inject the glue, and glue plug in the vein in the mandible here by the under fluoroscopy. And after the control, I can get rid of the lower part of this vein. After that, I put the new needle inside here, and inject the glue. And then after the treatment, the vein in the mandible has gone, right? And then you can see the glue in the mandible in the CT scan. So the patient is okay after the treatment, and we have the follow-up in 1 or 2 months. So I am 20 months old boy with history of the otomatoiditis, and then passed from the left ear. And the brain CT, you can see the marked swelling of the left face and some hyperdensity here. And in the contrast imaging, you can see the false aneurysm with the surround with the hematoma. In the bone video, you can see the otomatoiditis, and some of the destruction of the mandible is represent the aggressive infection around this area. After the IV antibiotic treatment, 2 weeks follow-up with the MRI, this aneurysm is more enlargement, and see some thrombosis around here, and patient refer to us for the treatment, this false aneurysm. For this disease, we diagnosis for the dissecting mycotic aneurysm. In the angiogram, you can see abnormal false aneurysm here, the contrast staining here, and no washout. When inject the ECA angiogram, you see here the aneurysm here is coming from the proximal facial artery. This one is the location of the neck. It's called neck of the aneurysms. So for the diseases, we need to sacrifice the facial arteries. We need the 2 choices: use coils or glue. For this, we use the glue. For inject glue, we put the micro catheter and put glue inside the false aneurysm a little bit, and then put the glue to the proximal facial arteries also. After the treatment, the false aneurysm has gone, the patient is good. Some soft tissue AVM like this is a maxilla AVM. You can see AVM here and here. Sometimes you need to consider that this disease also is called the CAMS disease. The CAMS disease is the AVM association with the AVM in brain and in the face, divided into 3 types. The CAMS1 associated with the hypothalamus, corpus callosum, hypophysis, and the AVM in the nose or around the orbit in the face. For the CAMS2, AVM occurs in the optic nerve, optic pathway, the retina, and the parieto-temporal occipital lobes and thalamus. For the face, it's involved in the maxillary area. For the CAMS3, the AVM occurs in the cerebellum, pons, petrous bone, and in the face, in the mandible. For this patient, the patient have the maxillary AVM, and when we search for the AVM in the brain, you can see the AVM here in the optic chiasms and in the optic nerve. So the patient has CAMS disease, CAMS2. So for the conclusion in the pediatric vascular disease, I think the non-invasive imaging should be the first modality for the diagnosis. For the cerebral angiogram is used for the treatment because the difficulty of the femoral punctures and the limitation of the contrast media. And some venous malformation can be associated with the pediatric dural AV shunt. Using of the pure glue and low BP, while glue injection in high flow AVF is used to prevent the glue migration distally. To say the contrast media is possible, no need to do the angiogram after every glue injection if you don't think it causes the complication when you inject the glue. So thank you very much.